My name is Benjamin Orr. I'm the president and CEO of the Maryland Center on Economic Policy. We're a nonprofit, nonpartisan think tank that believes every Marylander should be able to achieve their full potential in a healthy economy that offers a widely shared and rising standard of living. And we really believe that this conversation today is central to achieving that vision here in Maryland. So we're excited that everybody is joining us for this really important conversation. Raquel is going to drop a link in the chat for folks who subscribe to our newsletter and other materials. If you're interested, we'll be sending out a recording of this after the webinar is over. I want to start by thanking our sponsor, Kaiser Permanente. Celeste James, the Executive Director of Community Health at Kaiser Permanente, is here with a short welcome. Celeste is also a member of the Maryland Community Health Resources Commission. This past legislative session, the Maryland Health Equity Resource Act was approved, providing significant funding and state resources for Marylanders to address health disparities, improve health outcomes, and expand access to health care. So here's Celeste with a short welcome.
Hello, my name is Celeste James, and I'm the Executive Director of Community Health for Kaiser Permanente. For far too long, inequality has existed for many people of color and other groups that have been marginalized in our country. The COVID-19 pandemic has demonstrated the extent of this inequality, and we know it's broader than COVID-19. People of color face social injustice and numerous barriers to good health. Health equity is really the attainment of the highest level of health for all people. Achieving health equity requires us to value everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and structural, whether they're intentional or unintentional, biases in policies and programs. We believe at Kaiser Permanente that health equity requires a concerted effort to increase opportunities to be healthier for everyone, especially those whose obstacles are the greatest. We view our work in community health through an equity lens, which means we view community conditions and circumstances to assess who experiences benefits and who experiences burdens because of a policy, a program, or a practice. For 75 years, Kaiser Permanente's unwavering mission and foundational values have led us to embrace diversity, equity, and social justice. We, like so many of you, know we must continually challenge ourselves to do more to dismantle systemic racism, address social determinants of health, and create equitable economic opportunity for all. Kaiser Permanente is very pleased to be a sponsor of today's event.
Thanks, Celeste. So without any further delay, I'd like to introduce our moderator for today's conversation. Dr. Siobhan Laird is a longtime board member of the Maryland Center on Economic Policy and is also Director of Community Health Impact for Bon Secours Mercy Health. We will kick off the conversation in just a moment. We plan to leave plenty of time at the end to respond to your questions. If you are joining us on Zoom, you can submit them at any time using the Q&A button at the bottom of your screen. Please also note that this webinar is being recorded, and as I said, you will receive the recording and other materials via email afterwards. And with that, I will turn it over to Siobhan.
Hi, everyone. Thank you so much for that welcome, Ben. I really appreciate it. As he said, I work with Bon Secours Mercy Health, and my work focuses on reducing the health disparities in our communities, addressing the social determinants of health, and supporting the people in the 7 states that we serve to do that work. Today is not about me or my work, though. It's really about our panelists, and I'm really excited to hear the conversation. So I'm gonna kind of just jump into it. I think this topic is really important, as Celeste said, and I'm really looking forward to hearing what our panelists have to say. So I'm going to start off introducing our panelists with Maryland Senator Clarence Lam, who represents Legislative District 12, Baltimore and Howard counties, and is a public health physician at Johns Hopkins. Particularly during this time of pandemic, we need a better public understanding of the social determinants of health. Everything we do plays into our public health, and Senator Lam really exemplifies that. So Senator Lam, is there anything you would like to add?
No, it's a pleasure to be here and look forward to the conversation with all of you. I think this is an opportune time as the pandemic is still in its throes to discuss the social determinants of health and how we can improve health equity as a community. So this is a very important topic. I want to thank the organization for hosting this and look forward to our conversations.
Great, thanks so much, Senator Lam. Next, I'll go to Stacey Jefferson, who's the Director of Policy and Stakeholder Engagement at Behavioral Health Systems, Baltimore. Stacey also serves as the co-chair for the Marylanders Against Poverty, or MAP. Her pronouns are she and her. Stacey, would you like to say a few words?
I just want to say thank you for having me today. Like Senator Lam, I look forward to having this very important discussion.
Thanks so much, Stacey, for being here. Next, I'll go to Dr. Marisela Gomez. Dr. Gomez is the Community Health Consultant for Social Health Concepts and Practices Incorporated and co-founder of Village of Love and Resistance. Dr. Gomez, would you like to say a few words?
Happy to be invited and to be part of this panel and look forward to the discussion. Thank you.
And rounding out our panel is Chris Meyer, the lead research analyst at the Maryland Center on Economic Policy. His major areas of work include tax policies, school finance, and worker protections. His work focuses on the ways big picture fiscal policy choices can advance or hinder equity across all domains of life. I believe Chris will be joining us shortly. Correct?
Yes, he's running a little bit late.
Perfect. Hey, it happens to the best of us. So first, I'll start off. I think the place to start today's conversation is to talk about the role of race, ethnicity, and class in health and equity. Dr. Gomez, in your book, Race, Class, Power, and Organizing in East Baltimore, you discuss the way structural inequalities lead to unhealthy communities and unhealthy people. How do you think racial and class discrimination affect the health of communities?
Thank you. Thanks for the question. It's great. Great question. And I want to share my screen if I can do so.
Sure, I think our team will be able to help with that.
Great.
To release the share screen ability.
You should be able to now.
Okay, thank you.
Thanks for that.
Yeah. So I want to show just a few slides in the 5 minutes here. So what I'm showing you is get rid of these little boxes here. What I'm showing you is a map of Baltimore City. This is from BINIA, Baltimore Neighborhood Indicator Alliance. And one on the left, as you can see, is a map of our Black African American population in the city. The darker shade represents a higher percent. And it just reflects really the white L, where the least number of African Americans, and the white L, because that's where the majority of white identified folk are. And then the black butterfly, coined by Dr. Lawrence Brown at Morgan State, where the majority of our Black African American population reside. So we have the black butterfly and the white L. And so if you just look over on this map here and notice where how the black butterfly is mapping out in regard to percent of births where a mother has received early prenatal care during the first trimester, right? So in the black butterfly, we have the least amount of care, right? Because that's the lighter shade. So 37% to 43% here. If you look in the white L, you see 61 to 79%, right? So like almost a 30% difference between the amount of prenatal care during the first trimester that's happening in the black butterfly versus the white L. So this is at a population level, how race is playing out as far as healthcare access and healthcare delivery, right? So I wanted to give you kind of the meta big picture look, the population level look, that if you look at neighborhoods, it maps out and it's in Baltimore and in many cities that are segregated like we are from our history. And currently we can see this. And then we talked about the social determinants of health, and race is a social determinant of health, right? So it's old, it's not new. We've always been talking about social determinants of health since the 1800s. But there's one particular thing here, especially for this group, that disease is not something personal and special, but only a manifestation of life under pathological conditions. And that medicine is really a social science, and politics is nothing else but medicine on a large scale. And I think this really tells us a little bit about what is happening, the manifestation of life under pathological conditions. The pathological conditions are the power dynamic between people of color and white people, Black people and white people, right? And so those conditions of racism, which lead to discrimination, is the pathology that's leading us to have some of these health effects. Now, we create that through public policy, and I think the senator will get into this more, but because it's a context, right, that we are creating health inequities. We create health inequities. They don't just happen, we create them by discriminating in regard to social determinants or factors that affect our health. And these factors, as I mentioned, are race, their class, housing, employment, things that build our communities where people congregate in. And I mentioned power because it's important, because in our country and in the world, really, power is defined by race and class. Particularly in the US, we have to talk about the Civil War, we have to talk about enslavement, we have to talk about Jim Crow, we have to talk about urban renewal and gentrification that continues today. The book that was mentioned is the book I wrote about the biotech park of Johns Hopkins being built in East Baltimore and the displacement of more than 750 Black families. How this kind of serial forced displacement of Black families have resulted in fact affected their health because of people who have the power to determine how we do and rebuild communities. It then has an effect by race and class on their health. And when we look at it, if we get down into now the individual level, right? How does racism, how does classism, how do these kinds of discrimination affect our health? And so if we use the lower socioeconomic status and racial minorities as an example of a particular kind of social factor, what it is that it's the daily hassles of being in these particular groups, right? The discrimination that comes from being Black or brown or disabled or being queer or being an immigrant or speaking a different language or having less education, right? The discrimination that comes every day, right? That the body has to take on, this chronic continuous assault on our human being. It's a threat, the threat to our safety from living in neighborhoods that don't have affordable housing, where there's more crime because of the disinvestment, the chronic systemic disinvestment, and therefore the exposure to violence in these neighborhoods, less resources to cope with stressors when they impact us, right? So when something happens, do we have the resources to cope with it? Well, people with wealth have those resources to take care of it, but people without wealth, they don't have the resources. So it becomes a really bigger stress and it lingers, right? The decisions over daily life, they're more difficult for people in lower socioeconomic status, racial minorities, and access and control over decisions in life, in low paying jobs. How much control does a person have? There's so much research on this in low wage jobs and jobs that are not a stamp and bump on the clock before you go in. So all these things together result in greater stress leads to greater illness. And this is really on an individual level, how we see all these systemic things that are entrenched in our society, the structure of the systems that are entrenched, that bring this onto the individual, that congregate into certain neighborhoods, right? The zip codes determine our life expectation, right? And it's the stress of the daily life of a group of people exposed to these similar circumstances that then results in that slide that I showed you earlier, where there's less poor health, right? And so these two, I close with just these two slides showing that the race and the class do map onto each other often. As you see here, the greater percentage of folks who are Black African American living in the Black butterfly. And what we see here is completion rate for high school. That is, the lower completion rate for high school maps into the Black butterfly. It maps also as far as employed. There's less employed people in the Black butterfly. As far as percent of households earning less than 25,000, excuse me, that maps also into the Black butterfly. So we see how race and class together really has such a dramatic effect on our neighborhoods, and in turn has such a dramatic effect on the stress that people are exposed to and the inability to take care of it, and then therefore it builds up and the effect on our body, our mental and our physical health. And I think I'll stop there. Thank you.
Thank you so much, Dr. Gomez. I know we could honestly be talking about this topic for an extent much longer than the 5 minutes that you were able to put that together in. And one of the things I would like to appreciate is the social constructions that you have talked through and how those connect race and health, the historical context, the political context, all of these factors working together to connect the constructs of race and health outcomes. So I really appreciate that discussion and hope to dig a little bit deeper into that as we transition into. You started off talking about kind of Black and Hispanic communities, Black and Latinx communities. I'm going to transition into talking a little bit about the Asian American community. Asian Americans are often stereotyped as a model minority, which leads to the mistaken belief that they don't experience any health disparities and inequalities related to race and ethnicity. Unfortunately, that makes Asian Americans one of the most understudied racial ethnic minority groups in the US, which impedes health planning and supporting equal treatment of the Asian American community. Since the onset of COVID-19, Asian Americans and Pacific Islanders have experienced an unprecedented amount of anti-API hate, in addition to growing health inequity issues. Today, so many are for the first time engaging in advocating for the Asian American people, so not just the AAPI populations, but allies as well. Senator Lam, can you tell us about the ways all Marylanders can work together to reduce health disparity concerns that AAPI Marylanders are experiencing?
Sure, happy to do so. I apologize. I lost my video because I just lost power here, but I am on a laptop, so at least my...
I'm so glad we can at least still hear you. No worries.
No worries.
Happens to the best of us.
I apologize. I will try to regain my video shortly, but I am on audio only right now. So
no
yeah, I'm happy to talk about the AAPI community and social determinants of health and how this all plays into each other. So I think what Dr. Gomez presented earlier too is really relevant. And I think to put an exclamation point on the maps that you saw, we know that there are just huge disparities within Baltimore City and other places throughout Maryland as well, that when you think about it, that even just looking at life expectancy, I know we were looking at kind of maternal care there in the prior graphs, but when you think about the fact that areas like Roland Park have a 10-year increase in life expectancy over areas like Sandtown within Baltimore City, that these two neighborhoods are only a few miles apart, and yet there's a tremendous variation in the life expectancy there. And that's just reflective of one indicator in addition to the ones that you saw earlier in that map. The Asian American community is not immune to this. I think there's a lot of ongoing conversations within the community about disparities that exist. One, I think it's oftentimes forgotten that the Asian American community is also not a monolithic community, right? There are actually a lot of differences in health outcomes within different ethnic groups. So, for example, between the Chinese and the Japanese and the Thai and the Filipino, there's almost 2 billion people located in Asia. And so, the general grouping of the Asian American community into kind of one monolithic group is really, really difficult to be able to discern some of the more precise data that, indicates some of the health challenges that the community is seeing. I know within the Asian American community, there's been a push to try to actually disaggregate this data so that we have better information about how different communities and ethnicities within the Asian American population are affected by certain conditions. We know that, and I think this is probably preaching to the choir for all the folks here on this call, that without good information, it's hard to be able to target your interventions to improve outcomes. And in particular, with the Asian American community, without this aggregated data, it's hard to be able to target those interventions to figure out that and know that what's mostly afflicting the Filipino community might be different than the Japanese American community, and maybe different than the Chinese American, the Korean American community. And so, being able to catalog the data in a disaggregated form is incredibly important. I know it's a challenge because we've made strides to just have Asian American even separated out from other, right? So we've seen this, and I think other ethnic groups and demographics have seen this challenge too, that it kind of breaks down into white, Black, and then oftentimes other. And so, we've had to, and I think may had some success in being able to separate that out for the Asian American community, but we also recognize that we need a little bit more granularity there to be able to target this for folks. The other challenge that we're seeing, and I think, we've heard this too, that Asian Americans are oftentimes stereotyped as the mono minority, which leads many to think that there are no health disparities within our community as well. Asian Americans are actually one of the fastest growing, if not the fastest growing ethnic minority group here in the US. And so you bookend that with the fact that they're also one of the most understudied ethnic minority groups here. And there's a tremendous gap then in being able to address some of the disparities that we face. The ongoing challenge with the pandemic is certainly one that we are continuing to face as an AAPI community. I think everyone is probably at this point familiar with the fact that the heightened political rhetoric over the last year and a half with the pandemic that's been going on and still going on now has certainly increased the anxiety of the Asian American community because of a lot of verbal assaults and physical assaults have been committed against them. And so, I think it's interesting now that the community actually does feel the need to speak up. And we've seen more and more engagement within the Asian American community to push back against the hate that we've been seeing targeted towards Asian Americans. And so it is notable that they are engaging in the public process. A lot of Asian Americans culturally are very much more reticent and private about advocacy. But I think we've turned a page a bit with what's been going on, and the community has really been willing to stand up to lock arms with other people of color who face similar challenges, who they've been willing to go to rallies and protests and testify and provide information about these instances of hate against Asian Americans during this pandemic. And so, I think we're hopefully seeing more and more recognition that, a few things. One, the Asian American community is not monolithic. Two, that, we're not just a model minority where there are not many disparities and challenges that we're seeing. We face many of the same that other ethnic minority groups and demographics also face. And we also recognize that in order to be able to intervene a little bit more effectively, we have to be able to have disaggregated information that allows us to target our interventions to particular needs of the community. And that's a broad lesson that I think can be applied even outside the Asian American community. And then obviously during this time of heightened political rhetoric and the hate that's been kind of targeted towards Asian Americans since the pandemic has begun, just a broader recognition with the community that they do need to speak up and make their voices heard. And in locking arms and joining other brothers and sisters and other groups can really have a stronger voice in being able to push back against some incidents that we've been seeing and hearing about more and more. So the challenges of the Asian American community, I think, are a microcosm of what we see more broadly too. So appreciate the question.
I agree, and thanks so much for the thoughtful answer. I appreciate the deep dive into a topic that is not often discussed when we talk about inequalities, both in health and otherwise within the Asian American and Pacific Islander community. I'm going to shift gears a little bit. I know that Dr. Gomez touched a little bit on this topic in her talk or presentation about stress response, but I want to talk to Stacy a little bit, or have Stacy talk to us, I should say. We often hear about the ways racism leads to worse physical health outcomes, but behavioral health often gets less focus. It's just as important. It just doesn't get as much airtime, maybe a little bit more recently with the Olympics and recent sports heroes, as some might say, putting the focus on behavioral health and mental health. What are some of the ways you see racial disparity showing up in behavioral health outcomes? And are there policy changes your organization is advocating for that would help improve the health outcomes for Baltimore residents?
Thank you for that question. You are right. Many times, often, mental health and substance use disorder, which are the umbrella under the umbrella of behavioral health, are not talked about. The recent Olympics, but then also the pandemic has really brought a lot of those conversations to light, particularly in Black, Indigenous people of color. And so one thing I kind of want to goes with what Dr. Gomez touched on is there's a quote from, there was an interview done with Sharday Smith, who's an associate professor of the University of Illinois, and she stated it's through systemic racism that mental health issues arise and are maintained. And we definitely see in the system, in the behavioral health system, that race and health equities are also just as present and prevalent in that system as well. And so there are lots of barriers and reasons why we find that Black, Indigenous people of color are not getting the appropriate treatment, the quality care in behavioral health that many whites are receiving. One thing, there was a recent U.S. Surgeon General report on mental health that showed that that BIPOC communities have less access to mental health services than white communities. Also, they're less likely to receive needed care and are more likely to receive poor quality care when they are treated. There's studies that show that only 1 in 3 African Americans who need mental health care receive it, and that many minority youth with behavioral health issues are often referred to the juvenile justice system instead of specialty care compared to white youth. And so it continues to be an issue. There are 2 barriers, though, that I really want to focus on today that relates to some of the policies that we are advocating for with my organization. And so one is the lack of diversity amongst mental health and substance use providers, the language barriers and lack of culturally competent providers. This can really lead to underdiagnosis and misdiagnosis for mental illness. and people from racially and ethnically diverse populations. And there's a troubling study that actually found that Black and African Americans are frequently diagnosed with schizophrenia and less frequently diagnosed with mood disorders. And mood disorders are depression and bipolar disorder. And they are finding that where the difference lies and why this may be happening is there's a difference in how Black or African Americans express symptoms of emotional distress. And because of that, again, it's leading to misdiagnosis. There's data as of 2015 that 86% of psychologists in the US workforce were white, 5% Asian, 5% Latinx, 4% Black or African American, and 1% multiracial. And that's despite the fact that the US population as a whole is 62% white and 38% racial and ethnically diverse. The other thing is that we know, unfortunately, that more frequently, Black, Indigenous people of color who experience mental health and substance use disorders are often in jails and prisons, particularly during crisis situations, particularly mental health crisis. And we've seen this as well during the past couple years, is that oftentimes the police are called, which then leads to much more dangerous situations or persons being arrested. There's recent data from the Bureau of Justice Statistics that show that more than a quarter of people in jail met the threshold for serious psychological distress. And so that shows that, again, we have more people who are being arrested and sent to jails and prisons instead of getting treatment. And as we know, there are many more people of color that are in our jail and prison systems than getting treatment. And so also, even once they are incarcerated, they are less likely to be identified as having mental health problems. And that's because a lot of the screening tools are biased. And then in addition to that, because you're less likely to be shown to have mental health problems, you're also less likely to receive the help that you need once you're incarcerated. So it's just a vicious cycle. And so I know we'll get into this a little more later, but at Behavioral Health System Baltimore, so we oversee the system of care for persons for mental health and substance use disorder. And we also advocate for more access to treatment within that system. And a couple of things that we're working on is really looking at how do we expand the workforce and really ensure that we are getting more people of people from BIPOC communities that are in these positions and are providing services for mental health and substance use disorder. We are also working on a project to expand crisis services in the greater Baltimore region. And this is important because we are really looking at how do we have more mobile crisis team response, more clinicians responding to mental health crisis calls instead of the police. Because once again, as we know, for many communities, this having the police respond can often lead to deadly results. And so we are working on that as well. And as I said, I know we're going to get into much more a lot later about specific policies. But again, we really want to find how are we making sure that people have access to mental health care, but also quality access to that care. Because as we know, the stressors that Black, Indigenous people of color feel, especially due to a lot of the social determinants of health, really can lead to adverse outcomes.
Well, I really appreciate your passion and your work in this area, Stacey. I mean, it's much needed, and thank you so much for highlighting for our viewers some of the structures in place, the structural inequalities that lead to these health outcome inequalities, specifically in the behavioral health field. And I hope we're able to get some more time to dig even deeper to how we can be allies in the work that you do. Dr. Gomez, I know in that vein, the fight for health equity is exhausting. Marginalized and under-resourced groups can experience stressors that adversely affect mental and physical health, as we've just heard. What can we do as advocates, and what can allies and neighbors do to overcome racism and to support health equity?
Yeah, the idea of stress is huge, right? It's actually, the stress is a really big, it's kind of the thing that determines whether we're going to get sick or not, right? So stress is not just mental, the body's ability to respond to something that causes what we say like a reaction, a response. It affects the immune system, it affects the brain, it affects the nervous system in a bigger way. Cardiovascularly, it has huge impact. And so the way we experience stress and we take care of that as we do this work, this very important work, is also different depending on who we are. Because we have this perception in society that Black people, brown people don't matter, and that it just historically also that we have thicker skin, so we don't feel the same kind of pain. There's a lot of in the medical field, there's still the way we prescribe medication still has to do with the perception that a Black person doesn't feel as much pain, so they don't require as much medication for pain. And so they go out the door suffering, where their white counterpart, they're all taken good care of, right? So this taking care of, race and class comes in again, even in how we take care of ourselves, whether or not society deems it is okay for us to take care of ourselves, as was mentioned with the Olympics, right? The hate stuff against our sheroes when Black women are saying, no, I got to take care of myself. All of a sudden we're weak. The pathologizing of Black bodies and brown bodies is part of the need to self-care. It's part of the need to go back and make sure we are taking care of ourselves. We who are doing this important work are taking care of ourselves. And so what does that actually look like? It looks like a workforce or a workspace that actually allows time for a moment of rest after lunch. There's some workplaces that actually have a little quiet room for meditation, for yoga, to just sit, to just be quiet. Or some people go to their cars and just sit and take a nap. Used to be a time when we'd laugh at that and say that person's weak, but not so anymore. I mean, the data, unfortunately we have to wait on this data, right? But some traditions, Eastern traditions, have been doing this for many, many years. After you eat, you take a nap. It's common sense. You rest the body so it can digest the food, and you're not doing all this thinking, spinning mind. So these kinds of ways that we start to rethink this idea of capitalism and productivity that has driven us to the edge of our health, as that slide I showed from the 1800s, Virchow, who says that really it's this capitalist system, this productivity, that's driving our health outcomes. And this idea of taking care again, especially those of us who advocate for this, how do we actually, in my humble opinion, we have to model that. Just like how our Olympic folk are modeling that even at the supposed highest place where you're not supposed to stop, it is necessary to stop. So we have to do the same thing, even though we're advocating for these very difficult and necessary things. When it's time for us to stop and take a leave and go to the beach and just stare at the waves, things we don't talk about, things we deem as weakness, especially for Black women and brown women, right? People who have been carrying the load for so many years. And I know maybe this panel isn't thinking like this, but this is the reality of our life. And if we're really talking about race and class as indicators and determinants of health, we have to take care of the whole thing, not just a piece. So I think this understanding of where do each one of us sit in this continuity, this continuum of care, and also in the continuum of who deserves care, who deserves to be healthy in this society. That's the racial structures that are in place that tells us that determines what we're going to do. And then just taking time, in meetings, can we just stop? I invite Senator Lam in his meetings, because I know this is probably one of the hardest places to do it. to invite your colleagues to stop and take a breath in and a breath out before you have a meeting and close like that. Oh my God, like, why would we ever do that? Well, it resets the HPA axis, right? It resets the cortisol production, so it's not always up and chronic like this, which then leads us to be more susceptible to infections, and our heart gets to beating too fast, and our diabetes might pop up at 35 instead of 55 or 60. And so all these ways, taking walks, taking time off, being in nature, how do we do these things? Eating right. The simple things that we advocate for our populations that do the work are the things that we ourselves have to start taking into consideration. There's a lot more to say on this, but I'll stop there.
Well, I agree with a lot of what you said, Dr. Gomez. I know Bon Secours Mercy Health is part of Catholic Health, and we tend to open our meetings with a reflection. And even that time to center yourself in the beginning of a meeting is just immeasurably helpful. And I would recommend even non-Catholic health institutions to do something similar. I do want to shift gears a little bit and kind of tap into the knowledge base of Chris. Chris, you've previously looked at the ways the state's fiscal policy choices are reinforcing structural barriers and continuing to lead to worse health for Marylanders of color. What are some of the key policy changes that could help remove these barriers? And has the state made any progress since your report came out in 2018? I believe we're going to be able to drop a link to that report into the chat.
Thank you, Siobhan. Yeah, so that 2018 report, which was the first installment in our Budgeting for Opportunities series, looked at how the state's fiscal policy choices can either advance or hinder health equity in Maryland. And, unfortunately, historically and to this day, a lot of those choices are moving in the wrong direction. And so we showed that by looking at, a number of health outcomes, things like just health insurance access, things like infant mortality, or, things like lead exposure, asthma, and we, saw really significant disparities in a lot of those. And a lot of those patterns and trends have stayed fairly constant. So one thing that we saw was that we had really, while overall we've made a lot of progress, thanks in large part to Medicaid expansion in getting more Marylanders health insurance, we still have really stratospheric rates of lack of insurance among Marylanders born outside the United States. And that has, remained largely the same. So as of 2019, about a third of Marylanders born outside the United States who are not US citizens didn't have health insurance. And that was pretty much the same as the 2016 data that we looked at in our report. In other cases, we're seeing kind of continuation of positive trends that we saw already. So we continue, for example, as of 2019, to have higher rates of infant mortality among Black babies than white babies in Maryland. In 2019, about 9.3 Black infants per 1,000 live births died in their first year, compared to only 4.1 white infants per 1,000 live births. That's a really significant disparity. It's also a major improvement from the 2010 to 2014 period, when that was 11.2 per thousand versus 4.3 per thousand. So we are seeing that continued significant disparity that also is showing some positive change. But also we're seeing a continuation of a negative trend among Latinx infants are slightly more likely than their white counterparts to die during their first year of life, 5.1 deaths per 1,000 live births. But that has actually been on an upward trend over the last decade or so. And that's something that was the case when we looked in 2018 and is still the case now. we have made progress in certain areas policy-wise. In particular, some of the other panelists were talking about the role of stress in creating a whole large range of health outcomes. And that's something that we think is really important, and how economic security and stress and health are also linked to our public investments, not just in health, but in a wide range of policy areas. So we have made some progress in things like expanding some working family tax credits to families born outside the United States. So that, because it then strengthens economic security for a group who was previously left out, that then has the potential to improve stress levels and then improve long-term health outcomes. At the same time, of course, we've seen, really concerning disparities that should really give us pause during the coronavirus pandemic, both in rates of mortality from COVID-19, as well as stress and anxiety levels that we see in surveys, particularly among Asian Marylanders, showing that we still have a long way to go. And as we think about the policy choices that can move health equity forward, some of those are in health policy specifically, things like funding local public health departments, things like expanding access to health insurance, things like paying Medicaid providers decent rates. But also, we know that a lot of other public investments are necessary to promote health equity as well. Things like high quality, affordable housing without, poisonous lead exposure, or transportation that provides access to good jobs that then lead to economic stability. And so as we think of all these different areas that we're simultaneously underinvesting in, I'd say one of the main policy approaches that are necessary to truly achieve health equity would be to look at our tax code and close loopholes that we have, ask more of large profitable corporations and wealthy individuals, who we also know are overwhelmingly white, to ensure that we have the resources necessary to invest in health and in housing and transportation and education, and all these things that together holistically produce better or worse health.
Thanks so much for that, Chris. I think a lot of people don't often make that connection, so I appreciate you're connecting those concepts to help the tax code to health outcomes. Not very typical, I think. So we're definitely tight on time, and I want to make sure we at least get to a couple of these questions. But I'd like to invite the panel to share at least one policy change or system change approach or final thought that the audience should consider as we strive to achieve health equity, so that all Marylanders have the chance to live healthy, happy lives. I'll start with Stacy.
Yes. So one thing I know that I probably mentioned earlier was that the GBRICS project, which is the project that Behavioral Health System Baltimore, we are managing and overseeing, is an expansion of crisis services in the Baltimore region, particularly in Baltimore City, Baltimore County, and Carroll and Howard counties. And this would expand capacity of mobile crisis teams and community-based providers, which would therefore reduce police interaction and over-reliance on emergency departments when it comes to mental health and mental health crises. And there'll be legislation that'll come up to help support this project over the next couple of years. There's an investment of $45 million over 5 years that is being put towards this project. And there will be some policy changes that will go along with it. But it truly will help to reduce the police interaction and hopefully lead to less people, particularly BIPOC, in the jails and prison systems, and instead having access to treatment.
Thanks so much, Stacy. Senator Lam?
Yeah, I think one thing that we've been trying to address in the General Assembly is improving recognition across the state within our agencies, departments, and also the General Assembly of a health and all policies kind of perspective. That I know this has been an issue close to the heart of Senator Shirley Nathan Pulliam, who was with us as the former vice chair of our Education, Health, and Environmental Affairs Committee. And it's a policy that we've continued to try to champion in the General Assembly, where there's a recognition that as departments and agencies are crafting regulations or policy decisions, that they do need to view this through the frame of how it affects people's health, even in policies that may not on the face of it directly affect people's health, things like transportation policy, infrastructure policy, education policy, environmental policy, they all at some point do intersect with a community's health. And this is all part of that broader social determinants of health perspective. But being able to ensure that as different regulations and policies are crafted, that there is consideration given to a community's health, a community that's being affected or otherwise impacted by a policy decision, is at least putting health at a seat on the table to have an equal weight in some of these decisions and criteria that are being used to determine and ascertain some of these policies. And so that we are still championing forward. It's sometimes difficult because I know, with this audience, you all recognize how important all of these social determinants and how everything does play into our community's health. But, in the General Assembly, probably the view is not quite as broad. And so we've struggled to be able to get this piece of legislation even passed over the last few years since Senator Nathan Pulliam has left the General Assembly, because it's still a critically important issue. Many of us still recognize that as something that needs attention and continues to need to be addressed within our departments and agencies. And so we're going to continue to work forward on this. I think health equity will be much helped if we're able to get a health in all policies kind of perspective across our state government. So just one more piece that we're hoping to be able to address. Maybe back to you, Siobhan.
Agreed. Thank you so much, Senator Lam.
Sure.
I had the pleasure of working for Shirley Nathan Pulliam as well, and agree on her contribution, and I'm thankful for yours as well. Chris, any last thoughts to add?
I would definitely, echo Senator Lam's thoughts about how every policy choice can affect health. And therefore, I really like that idea of including health impact analysis on all legislation. And then, on that note of kind of the holistic impact of all fiscal policy choices on health, I would say, a major step to have the resources to invest in health equity would be to close corporate loopholes and loopholes that enable large businesses not organized as corporations to reduce their tax responsibilities, as well as ensuring that we're getting adequate revenue from wealthy individuals, so that we can have the resources that we don't have to make choices between health insurance or local public health departments or housing.
Appreciate that, Chris. And I will turn lastly to Dr. Gomez.
Yeah, thanks so much. One of the things I would suggest here is the guaranteed basic income, the universal basic income guarantee. It's different languages depending on where, but this is something where it's actually at the federal level now. A bill is introduced called the Support Act, and it's requesting $1,200 a month to every household, every person, actually. And we are looking at it in the city. There's a task force. It was introduced in the legislature in Maryland a couple of years ago. I don't think it was introduced again this year. I may be wrong. That's a shame that it wasn't. But things like this, right, where it's called guaranteed basic income, where everybody gets this income. It's not means tested. You just get it. And the data that has come out so far, where this has been piloted or in other countries and in other cities, has shown that there is an impact on a person's health and well-being when they receive this money, regardless of income. And it gets at that idea that of this fiscal responsibility, you know, a couple questions around low income and how do we prevent health inequity. If we look at the social, political, economic determinants of health, holding everything, then we have to get at these systems that are inequitable and unfair. So if we can do a basic income guarantee that starts to leverage and build while we're getting at the transportation, while we're getting at the taxes, while we're getting at these institutions, these nonprofits that are using pilots, payment in lieu of taxes, and not really paying their fair share into our tax base, so that we can really help all Marylanders. Really, while we're getting at that, we can start helping with this kind of universal basic income to start to get people a little bit more balance, so they're not stressing out about where their next paycheck, and if their car stops on the road, that can mean a whole week of no work for someone who's poor, while for someone who's wealthy, you know, they just call AAA and they take care of that right just like that. There is no stress. That difference right there, that's what's impacting our health, not just our mental health, but our high blood pressure and everything else that we say is health.
Thank you so much for that, Dr. Gomez. Well, we actually ran out of time. Thank you so much to the panelists for all the information that they've shared. I really found this to be interesting. And I'll say to the viewers, to the folks who have participated and submitted questions, we're either trying to address some of them in the Q&A, but we'll try to share resources and responses also by email later. So don't think that we have ignored these questions. Ben, I'm going to turn it over to you to close us out.
Thanks, Siobhan and Dr. Laird and all of our panelists. That's all the time we have. I wish we had half a day to talk about this important issue. There were definitely some important and thoughtful questions submitted, and like Siobhan said, we will follow up and work with the panelists to follow up. Please do stay in touch. You can keep up with the latest Maryland policy developments by following the Maryland Center on Economic Policy on Facebook or Twitter. And sign up for our email list to make sure you hear about future webinars. We will post the recording on our website, and you will also receive an email with a link to the recording of this webinar, as well as our previous webinar and the registration link when it is available for our third and final in this important series. So with that, thank you to everyone. Thank you to our panelists, and have a good rest of your afternoon.
Thank you.